Good morning, everyone. Welcome and thank you for joining us on this blessed and beautiful Friday. Again, it's the last Friday of the month and it's CME time. So this morning, we are joined by a very special guest from South Africa, so the other side of the world. And today we're being joined by Dr. David Alexander Thompson, who is presently a consultant in critical care and transplant. And Dr. Thompson will be introduced by our very own Dr. Shani Knowles, who is our consultant pediatric surgeon in our Department of Surgery at the Princess Margaret Hospital. Before Dr. Ashani comes on to introduce Dr. Thompson, I'll just highlight that in view of this morning's presentation, Dr. Thompson has done a research publication on determination of brain death, death by neurological criteria, the World Brain Death Project. And so welcome, Dr. Thompson, and Dr. Shani Knowles, you can take it away and introduce our speaker for this morning.
Okay, good morning, everyone. So it's a pleasure to introduce Dave. So Dave is a friend who I did general surgery with, and he went on to actually do a trauma and critical care fellowship, and also he did transplant. There's a Commonwealth group where he's working with actually some Caribbean transplant, Dr. O'Shea and Dr. Vanterio Taylor. And there's a group where they're doing quite a bit of work. And he's been involved with the teaching of our residents. So it's a pleasure to have him here. And he's going to be involved with definitely our surgical program, strengthening our critical care arm. So I present you Dr. Thompson.
Thanks very much, Shani. And thank you all for the invitation to speak. It's really is an honor to reach out across the world this way. Can everyone see the slides? Just wanted to double check.
Yes, we can.
Perfect. I'm going to talk around death determination. My disclosures are that I've got no financial disclosures of conflicts of interest, but I am a transplant surgeon and an intensivist, and all talks need context. So I'm working at Preconditions Hospital in the University of Cape Town, South Africa. When Shani asked for a topic, there's nothing more universal than human mortality, and currently it's still sitting at 100%. And we work in our best intentions to maximize this and the quality of life for this, but it's still one of the unanimous things is that we will all be faced by this eventually in some way, shape, or form. So a very good article is the International Perspective of the Diagnosis of Death, written by this group out of UK, Canada, and Australia. And it gives a really good overview of this practice around the world. And then there's various aspects to it. And we always focus on the brain death aspect, but we're actually much more familiar in the hospital context of the circulatory death criteria. And there are actually somatic criteria as well, because even the paramedics by the roadside aren't necessitated to bring in patients in certain situations to hospital for a pronouncement of death. So society has various ways of determining death. And those are set at an intersection between medical science and cultural and spiritual beliefs. And if I look at our own guidelines, we open with a statement that says death is a medical occurrence that has social, legal, religious, and cultural consequences, which requires common clinical standards for its diagnosis and legal regulation. So we've got the two types. So we've got the brain death and the circulatory death that we're going to deal with in this talk. And I'm going to start with highlighting what the preferred terminology is, because it always gets a little bit muddied, and people are coming around to using a brain death or a neurological determination of death as the first criteria or a criteria, and then circulatory death. So not cardiac death, but circulatory determination of death. And I hope we all realize that there's no need to fit our coffins with bells anymore. There's lots of things in medical science where we're not 100% certain and sure, but when it comes to death, this is the absolute part of our science, and we can do this with complete certainty in the modern era. So I'll start with brain death. This has come into effect and was popularized, but codified in this seminal paper in 1968, a definition of irreversible coma from the ad hoc committee of the Harvard Medical School. And I say 1968 because this is actually the year after the first heart transplant, but it's really important to realize that the problem of certifying people brain dead on ventilators came about from the polio epidemic in 1952. And a French author, Monet, actually classified coma de passé when they realized that they were treating a lot of patients and they'd end up in a situation where they could keep the body going, but there was no neurological activity whatsoever, and there was no recovery in those patients. So the determination of death was codified in that paper, and we applied medical standards to it. But what has happened around the world is there's actually a lot of variability in how this is applied. And that's not just within the United States, but it's a worldwide thing. And even in Europe, they're looking for standardizing it across multiple platforms. It gets even more complicated when you start to get into the emotional realm of children. And there's lots of variabilities around the world. But what's actually important to realize is that no one has ever recovered from being correctly clinically certified dead. Now, how do you go about approaching it in a setting which in Africa is quite common, that there's no legal regulation in terms of it being written into law precisely how you should practice your medicine? And it's interesting that the United States passed the Uniform Determination of Death Act in 1981 to try and help to formalize this practice across all their states. And it defined death as an individual who has sustained irreversible cessation of circulatory and respiratory functions, or the irreversible cessation of all functions of the entire brain, including the brainstem, as being dead. So this was a way that the medical fraternity could then build the practice guidelines and they would apply to this definition of what death is. And I think the key word here is irreversible. So thank you for introducing me. As I was part of this project, the World Brain Death Project, which was led by Professor Jean Sung and Prof. Shemi from Canada and a few other core thought leaders in this process. And they pulled off a very good document that could then build out of a practice coordination of intensive care and neurological societies under the banner of the World Federation of Societies for Intensive and Critical Care Medicine. And if you want an international document related to determination of brain death or death by neurological criteria, this paper was published in JAMA in 2020. And although the appendices weren't published, if you've got any question, you can easily delve into the 13 supplementary appendixes that deal with any question you may have and would be able to show you the latest evidence base graded as per the criteria of any consensus statement. And what we did in South Africa was we actually leveraged this work with its exceptional literature review to get everyone to sit down, because it might surprise you that South Africa, where we were performing transplants and did the first heart transplant, we didn't actually have national professional guidelines setting the standards for how to determine death. It was actually just held to accepted medical standards. And we've got a National Health Act from 2003 that does stipulate that brain death is dead. So that is death. So that is codified into the legislation. And it stipulates in the case of organ donation that 2 doctors must certify the death, 1 with more than 5 years of experience. So I think that's important to realize that you do need some acknowledgement that brain death is death. But it's interesting to see how it's gone around the world, because some countries were skeptical of this and have passed legislation that mandates that you must use an EEG in the certification of brain death. And we'll get to the sensitivity and specificity of that in a later slide. So I think what it comes down to for me is, if you're applying this in your clinical practice, it's a relatively rare event for clinicians to be involved in this. Okay, and you need to use checklists. We know our pilots use it to fly us around in planes, and it's the basis for making sure you make no fundamental errors and you tick all the boxes. Our checklists provided with our guideline and come with advice sheets on the process of the testing, and to keep you on a standardized form of precisely how would you stimulate the patient, where would you be looking for the response. And the guidelines are needed and needed to be updated, because there's difficult clinical situations and settings where you may have Ecmo. People may be relying on MRI and CT scan, and what is their sensitivity and specificity for brain death diagnosis. There are new modalities such as transcranial Doppler is validated to assess someone as brain dead, but that comes with caveats. So even though it's internationally recognized, it is operator dependent. You need 2 operators to do 2 exams, 30 minutes apart. And in the South African situation, we don't actually have the expertise to do this or pull this off. So it's not featured in our guidelines because of local considerations, but it would be fully explored, and there's recommendations related to do it in the World Brain Death Project. And I mentioned EEG, and this is for me an important reason for why you shouldn't legislate how medicine should be practiced, because the legal system moves at a pace that is incredibly slow. But if you actually look at the latest evidence related to EEG, it's 70% sensitive and specific. And that's even using somatosensory evoked stimuli in terms of performing the EEG. And I think we can all agree that we wouldn't really be satisfied with a 70% chance of being correctly diagnosed dead. And yet this is legislated in quite a few jurisdictions around the world. So I think we need a broad overarching recognition of the categories of death and the principle outlining it for when the legal system can take over. But then I do think it's up to professional guidelines and how we educate our medical professionals in order to do this in the right way. In terms of our documents, we use non-American spelling in the South African guidelines. And you've got to start any document with defining what are your terms and how you're using certain words. So, for example, an ancillary test is often thought of as being a replacement test that can stand alone on its own. And it's really important to realize that an ancillary test, if you resort to it, is actually just an additional test. And you're probably choosing the best test in a specific situation, and it's complementary to the fullest clinical exam that is possible to perform. You've got to define how you're defining brain death and the terms you're using. A confounder is a situation where a clinical test may be unreliable. And accommodation is actually the term that we would use for a period of somatic support to allow for a family to process the diagnosis of death. Because I think with death sitting at the intersection, it's not really a question of, I did it and now my job is done. There's an element of communicating this to the family. So that's important to realize. There's a focus on clinical determination, and this slide just flashes the importance of this, because actually there's no substitute for actually causing a stimulus and looking intently for a response. And this is the problem with the ancillary tests, because they're all static pictures, and that's why it's really important to focus on the clinical determination of death, which can be done to a minimum standard, and that was set in the World Brain Death Project, and I'll take you through some of those standards. So there are preconditions for the testing to be valid, because you'll all hear those sensational newspaper articles of someone waking up after being declared brain dead. Invariably, it's partly due to a breakdown in communication, and it would be typically in a situation where actually, even if the testing was performed, it wouldn't actually be valid. So someone's hypothermic and pulled out of ice cold water and hasn't been warmed up for long enough, or there's a drug confounder that hasn't been appropriately assessed for. So what are those prerequisites? Well, it's the coma, it's normothermia, it's have you actually resuscitated your patient, and excluding a significant metabolic, electrolyte, or endocrine abnormality, or any of our drugs being excluded. So just to say, you do need to know the cause. If you can't come up with a cause for the brain death, then you really need to start looking for other causes, because you need to have an explanation for this. Temperature needs to be set at 36 degrees. This used to vary around the world, with people choosing temperatures from 37, 36, 35. And the World Brain Death Project settled on 36 degrees, which I think is completely logical. Blood pressure needs to be resuscitated. You can't certify a patient who's under-resuscitated as being brain dead. The other preconditions are that you need to exclude the drug effects. There is a duration of observation needed to be required after therapeutic hypothermia or an anoxic brain injury. And you need to go about excluding the severe abnormalities that I mentioned before. You need at least one ear and one eye to perform the testing, and you will perform them in both if you have both available. And you need to have the ability to perform an apnea test. And there's a group of patients where it's not appropriate to do an apnea test, and then you wouldn't do it. You would do the other testing and follow through with an ancillary test. So how do you exclude drug effects? Typically, we would allow 5 elimination half-lives of the drug to pass before making an evaluation of brain death. And you need to take into consideration the dose, the elimination half-life, which may be influenced by age, prolonged by organ dysfunction or prior hypothermia. You can use an appropriate drug antagonist. You can measure drug levels. And if you're not able to sort those things out, then performing ancillary testing becomes appropriate. And I would say to you, beware of barbiturates, because if you look in the textbook, if you use phenobarbital, we don't actually have it easily available here anymore, but if you've got someone with seizures and they got a big dose of phenobarbital, I think the half-life is 72 to 128 hours. So you can imagine 5 times that half-life is quite a long period of time. So then it's definitely much more appropriate to perform an ancillary testing in that setting. The time period for observation in our South African group of experts, when we sat them down, it was felt to be too complex to just come up with one standard, one size fits all. You know, a transhemispheric gunshot intubated at the scene by the paramedics, brought in 2T, and not given any drugs. It was felt that you didn't have to have a period of observation for that type of patient. But I think in certain situations, we aligned well with the World Brain Death Project, which is in cases of anoxic brain injury, that there should be a 24-hour observation period. In cases where therapeutic hypothermia is used, we don't actually practice this in South Africa, and prefer to leave patients normothermic. There should be a 24-hour period of normothermia before an examination for brain death. And we always advise a cautious approach in pediatrics. Okay, it's a much more emotional field, and we would advise, adding extra time into that situation. But it's not a prescribed period that has to be adhered to. Excluding other mimics, it's important to realize that brain death itself leads to a lot of physiological derangements in the body. and hypertension, hyponatremia, diabetes insipidus frequently accompany it. And so it's important to realize that those may be the effect rather than the cause of the cessation of brain function. And so you need to make sure that you do exclude the main ones. And in cases where you don't have a diagnosis, you need to exclude all the rare ones. So it's recognized that sodium can cause responsiveness from a level less than 115 or greater than 160. Low potassium can cause flaccid paralysis below a level of 1. The guidelines actually recommend a level being maintained above 3 for physiological hemostasis. And so it's just to be aware that an exceedingly low potassium level can cause paralysis. And the same is true for phosphate and magnesium. You're doing blood gases on these patients, so you do need to check that there's no hypoglycemia at the time. And hyperglycemia can also cause a mimic of a coma. And so you need to make sure that your glucose level is somewhere between 4 and 20. The really left field diagnoses like myxedema, and Addisonian crisis are extremely rare and unlikely to coexist in the presence of known primary pathology. So we don't routinely screen for those. But if you suspect them and you don't have a diagnosis, then it's obligatory to ensure that you undertake some sort of examination for this. This would entail bringing in another consultant for these type of difficult situations. But the vast majority of patients, you can go through the checklist and actually certify patients 100% certain with completing the checklist and making sure that you've got all your ducks in a row. In terms of the imaging, we recommend that when it's available to assist with establishing the etiology and confirming the brain imaging, but it's not necessary to do it. So if you have the cause, be it the gunshot, then you don't have to have a CT scan. But it really does help in discussions with the family to be able to show some sort of structural damage to the brain. Just in terms of the testing process, this comes down to rigor and how do you ensure that people do this appropriately? Again, this comes back to checklists. I've already mentioned that you need to be able to examine the brainstem reflexes. And then apnea testing is precluded by severe hypoxic respiratory failure or a high cervical cord injury, in which case ancillary testing is needed. Also, in some of the neuromuscular causes, you're not able to do the apnea testing. So what is the examination? You're going to go through the pupils. Are they fixed and non-reactive? Is there an absent corneal reflex? I always tell the students to be careful of the corneas because they may be possible to be donated. No gag reflex, absent cough breath reflex on deep suctioning down the tracheal tube. No facial grimace to supraorbital pain. Remember, someone with a high spinal injury is not going to be too impressed if you start talking about brain death because you're giving a sternal rub and he's not moving his limbs. There should be an absence of motor response in all limbs, although spinal reflexes may persist. The ocular vestibular or cold caloric reflex must be demonstrated to be absent. And then the final one is apnea testing, which should reveal that there's no spontaneous respiration in the setting of a high CO2 and a lowered pH. Just to say that the doll's eye test, which often gets taught, and you have to tell the students, it's an expensive doll where the eyes move, or the one where you draw the eyes on, which is brain dead. And this you don't need to do anymore because the guidelines say cold caloric testing is a much more standard stimulus and it's testing the same level of the brainstem. But if you are still teaching it, it's the doll who you draw the eyes on who is brain dead because there's a reflex in the brainstem to try and keep the eyes focused and then they would move counter to any head movement. But this is not part of the guidelines. The same is true for the Atrophy Test, where you can demonstrate that the vagal nerve, which comes from the brainstem, doesn't have an effect on the heart rate. This compounds assessments of the pupils, and we don't use it in our guidelines. So we've got little provisos next to how you actually do this in our advice sheet. I'm not going to go through these with you now in the interests of time. What I am going to do is give a little bit of detail on the apnea test because it always confuses people and it's good to have a nice standardized approach to that. You need to be able to pre-oxygenate the patient and then you need to be able to give them some sort of oxygen supply free from the ventilator. We advise using a T-piece. You can use a suction catheter to do it, but it could occlude the tube and precisely what rate do you use. So we actually advise just using the T-piece. And we've got an advice sheet with our guidelines. And I'll take you through these now. It's advised that 2 doctors perform a single apnea test together. And for the testing itself, the 2 doctors can do it together. As long as they're applying the checklist rigorously, it's felt that that doesn't increase the accuracy of the test by staging it and separating the procedures. 2 doctors are likely to work well together, and they can correct each other, and it doesn't add to the rigor of the testing. Only proceed with an apnea test if all the other brainstem reflexes are absent, because you don't need to do it. If you've got one of the reflexes there, then you don't need to perform it. You're going to pre-oxygenate the patient, and you're going to perform a baseline ABG, showing that the CO2 is within a normal level, and then you're going to supply the oxygen and then observe the patient continuously for any breathing. How long do you wait, or when should you stop? Well, you should stop if you see any respiratory effort, if the patient becomes hemodynamically unstable, or they acutely desaturate or develop an arrhythmia. It is recommended that you do a quick blood gas at that time, because if they have met the threshold and haven't had any respirations, then you would be certifying them brain dead, because they've fully satisfied the criteria. The interpretation is that you would need on that blood gas to show the pH is under 7.3 and the PCO2 is greater than 60 millimeters of mercury or 8 kilopascals. In pre-existing hypercapnia, so COPD patients, you need to show a rise of 2.7 kilopascals and the pH becoming acidotic. Okay. The duration often comes up. We all often teach just a standard 10 minutes, but it is actually variable, and it depends on how hard you've been ventilating the patient beforehand. Because if you've been hyperventilating him, then the CO2 may have a longer distance to rise up. So if you're starting from normocapnia, it typically takes 10 minutes to reach a KPA PCO2 of 8 after 10 minutes. And if you haven't reached that threshold and they haven't taken any respirations and they're still stable, then you can just prolong the time period and maybe do another blood gas after 5 minutes. Yeah, and if you're starting at the upper limit of the PCO2 on the ventilator, so you've had the breath rate down at 12 for a while, then you don't have so far to go to show that they're not actually spontaneously breathing. And there are things to do if they become hypoxic. You are allowed to give them 2 positive pressures and continue the apnea testing. But typically the best way is to adequately pre-oxygenate and have the patient recruited. And then our checklist actually has the time of death, because the time of that apnea test proving that they haven't taken their breath is actually the legal time of death. And you can fill that in, and we've got the 2 doctors to complete that. There's no evidence that a time period between the exams is required, and there are risks associated with the apnea testing, so that's why it's advised to do it together. There are challenging clinical situations for brain death, and just remember, you always have colleagues to ask for advice in this situation. In terms of Ecmo, I'm not going to go through the details for this, but it is actually possible to do apnea testing on Ecmo, where you alter the flows and you can create that stimulus in terms of the acidosis and the higher CO2, and then you would be able to perform an apnea test in the patients. In terms of ancillary testing, I think it's really important, I've stressed it, that the clinical exam is the backbone, and you need to complete this to the fullest extent possible. And there is an appropriate choice of ancillary test. It depends on what's available. It depends on what the confounder is that they're trying to deal with. So the indications for ancillary testing would be the inability to complete the full clinical exam, confounding conditions, uncertainty regarding interpretation of spinal reflexes would also be an indication in my book, and pre-existing severe neuromuscular disorder would also be an indication for ancillary testing. The preferred ancillary tests demonstrate the absence of intracranial blood flow. This is the preferred method of testing where available. This is the vast majority of brain death patients. I would think about more than 90% are this type of patient. You can have the case where the brain neurons are still getting perfused, but they're non-functional. In cases of severe hypoglycemia, and the neurons may have died in the setting of actually preserved blood flow, but this is the vast minority of cases. Because if you think about it, the mechanism for brain death is the brain suffers the injury, it swells as a result, and that compromises the blood flow into the brain and sets off a cascade that ultimately results in the brain not getting any blood.
So you can demonstrate this with radionucleotide studies, 4-vessel cerebral angiography, and transcranial Doppler. And here you can see a patient on the left is alive, and the patient on the right is very definitely not alive. And you can see the cutoff of the carotids coming up. And here's a radionucleotide scanning showing that the tracer gets to the scalp, but none of it is entering into the brain. Transcranial Doppler, I've mentioned already, you can also demonstrate the lack of flow into the brain, but it's quite difficult to interpret. You need 2 examiners, and there can be vibrations that can mimic flow, so you need to be quite experienced to be able to interpret this. EEG, as I mentioned, potentially has a place in patients who have decompressive craniectomy, which may have re-established flow into the brain, and you want to prove that there's no cerebral activity. And just to remember that the 70% sensitivity and specificity, but also if you've done an EEG and there's any form of activity, then the patient's not brain dead. Okay, then they're having seizure activity, and that means there's activity in the brain, so they can't be certified brain dead. MRI and CT scan are not currently validated as standalone tests for determining the lack of blood flow. The resolutions are getting better and better, but if you look at the literature review, it's not recommended that they be used in isolation, but they're frequently used, and they're very powerful in terms of coming up with a primary diagnosis, demonstrating that there's a degree of problem, but as a standalone test, they're not actually the recommended assessments of absent blood flow into the brain. Just in terms of pediatrics, because that always comes up, and the pediatricians always used to keep their own standards different from adults. But actually, the guidelines say that the same standards for adults apply to children. A cautious approach is advised, with serial examinations recommended. You can't diagnose brain death in neonates under 36 weeks of completed gestation. And in neonates, so under 4 weeks, the sucking and the rooting reflex should also be assessed, right? Ancillary tests is not routinely required. It's quite often legislated around the world, just because of the extra emotional anxiety related to the children. But the clinical testing and repeating that and good communication is actually adequate and the recommendation of the guidelines. But you can add it in certain situations, and getting second opinions and getting an additional test is not unheard of in terms of trying to facilitate the communication of the diagnosis. You should use a T-piece because those pediatric ET tubes are very small, and giving it via suction catheter might occlude it and cause barotrauma. And you can't actually do an apnea test in children with cyanotic heart disease, so then you do need to use an ancillary test in that situation. The World Day Brain Death Project, as it relates to pregnancy and brain dead pregnant women, because it's a world project, needed to be applicable across multiple jurisdictions and keep multiple people happy. But actually, it does come down to what your local guidelines are in terms of fetal maturity and when does a fetus have rights. So in South Africa, you have to be born to gain your human rights. So the fetus doesn't have rights, and the mother takes priority. But in the situation where it was a brain dead pregnant patient, we advised that it should be an MDT that discusses taking this on in terms of maintaining a body for the sake of the fetus and trying to deliver it. And when you look at the literature, the fetus, the baby does try come out very early on. So as soon as you can potentially deliver that baby and you've got a chance of lung maturity, that should be the time taken to do it. It's very rare that you can maintain a body completely stable. And I remember a case where we had a mother come in with liver failure with us, and she was pregnant and she was brain dead. And actually the metabolic collapse happened acutely when the fetal liver passed away, and the fetal liver actually got overwhelmed because the baby's liver was actually trying to keep the mum going to a degree. It's important to realize that we have tried to maintain brain dead patients, and you'll always read about the cases in the United States and in Canada, Jahim Akmar, and it's a very vast minority of patients who can be maintained for a long time on a ventilator. In about 80% of patients, the metabolic collapse of the body follows a brain death diagnosis within 72 hours. So it's just important to realize that. Typically, the adolescents, very young, and those are the tiny minority of patients who are actually able to be maintained brain dead and have the body maintained on mechanical support. And then dealing with a grieving family, because this is a big part of dealing with end-of-life care. And it's really important to realize that it's a sequence of conversations, and that it is actually appropriate to give a family a period of time to come to terms with the diagnosis. I think it's important to be pragmatic at end of life, and you should tell the family that you're considering doing the brain death testing, and to potentially have them there for the brain death testing can help with their process of understanding. And it's ethically and legally appropriate to end somatic support for a body when the family has been adequately counseled on the diagnosis of death and of organ donation explored. It's advised that an additional clinician in the hospital can provide the family with a second opinion. We wouldn't advocate moving the patient to a different institution for that opinion. That would be a failure of communication in the majority of people's view, and that you should actually be trying to deliver that service to the family. But it is difficult. And in the setting of resource constraint, which is often the case with us, there's definitely a rationing of resources that's going around. Organ donation, end-of-life care should, as a standard of care, explore the patient's wishes to organ donation, and somatic support of a brain-dead patient until their wishes towards organ and tissue donation can be explored with the family is encouraged. The recommended time for such an assessment is when a decision is made to perform brain death testing. So if you've decided to perform brain death testing, do have a discussion with the transplant team at that point to assess the potential for donation, so that you go into the end-of-life discussions knowing what is possible. It's not that the transplant team wants to insert themselves into the end-of-life discussions, but they do want to appraise you of what the options are, because being able to transition or give the family the option can really give them some comfort that something good has come from their tragedy, because it's always a tragedy for the family's point of view. And I always quote this UK potential donor audit in most of my talks, because they actually reviewed all the patients dying on ventilators. And according to the medical notes, in 26% of cases, the patient was GCS2T, and the doctor didn't bother to test for brain death. In only 4% of cases was there actually a medical contraindication to donation. In 7% where they had certified death and there was no contraindication, they didn't ask the family whether they would like to donate. And they had a 36% refusal rate in the UK. And the donor was in 8% of cases too unstable to get to theatre in order to recover the organs. So it's just important to realize that it really does start with how we practice end-of-life care and communicate it, and our confidence with being able to go forward and do this testing in a meaningful way and a confident manner. Just in terms of training and timing, it's really recommended that all doctors should be trained in the determination of death, that you use checklists, and then as soon as it's challenging, you must be consulting an experienced practitioner. And then the other part to realize is that the timing and the certification is when the second apnea, or hopefully you've done one apnea test together. If you're in the case of an ancillary test, it's when that ancillary test has been formally reported that is the legal time of death. And then your documentation standards, all these end-of-life things come down to good documentation. So you do need to write down the cause of the coma, that there's no confounders present and you've considered them all, the details of the clinical testing performed, is there any imaging results, and the reasons for any ancillary testing, what the time of death is, and the legible signature of the doctors doing the signing of the documents. And then we've basically covered less than 1% of hospital deaths, because brain death is a very rare occurrence. I am going to go into circulatory death with you quickly. Unfortunately, this also suffers from a degree of variability in how do you go about it. I mean, how long do you wait? from the absence of what? Respiration, movement, auscultation of the heartbeat. Are you waiting for an ECG flatline, an arterial line flatline? Are you doing an echo on the patient? And this varies around the world. In Germany, it's, I think, 4 hours still. And so that's a long time. In Italy, it's 20 minutes. And in the rest of the Commonwealth, it's pretty much 5 minutes. And in America, it's 5 minutes as well. And it's important to realize that there's a context for circulatory death determination, because you can resuscitate hearts for a long time and get circulation back. So one of the following criteria must be met to pronounce someone dead on the basis of circulatory grounds. It's inappropriate to attempt CPR, attempts at CPR have failed, or it's a planned withdrawal of treatment aimed at sustaining life. Okay, so you've reached the point of futility and non-beneficial treatment, and you're actually withdrawing your treatments because they're just prolonging suffering. And treatment may be withdrawn because it's been decided to be of no further benefit to the patient and is not in his or her best interest to continue, or it's in respect of the patient's wishes via an advance directive or refusal for treatment. How and how long the patient should be observed by the person responsible for confirming death for a minimum period of 5 minutes to establish that irreversible circulatory arrest has occurred. You would determine this by the absence of a central pulse and palpation or the absence of heart sounds and auscultation in the vast majority of cases. In places where there's invasive monitoring, you can use the absence of pulsatile flow on your A-line or the absence of contractile activity using echocardiography. You don't recommend using the flat line on the ECG trace because intermittent electrical activity of depolarization can actually occur up to 30 minutes after complete loss of cardiac output. The reason we use 5 minutes is that the ability for the body to auto-resuscitate the heart in a setting where you're not going to do CPR and there's been complete loss of circulatory output is actually 65 seconds. In that setting where you're not going to touch or do anything, the heart will not auto-resuscitate after 65 seconds. It's also felt that after 5 minutes of no output, the brain would have suffered irreversible damage. So what you would do at the end of your 5-minute period is you would, of continued circulatory arrest, is that you'd assess the pupils for response to light. Any motor response to supraorbital pressure should be confirmed, and the time of death is then recorded at the time at which those criteria are fulfilled. We again made a nice checklist to make sure that it's inappropriate to do CPR if you're certifying someone dead, or the time at which you stopped everything formally. And then you document that there's absence of mechanical cardiac function, and that you've observed the patient for 5 minutes, and that you check that there's no neurological response in terms of pupils and supraorbital pain at the end of that 5-minute period. And typically this is done by one doctor, but in the cases of organ donation, as you're aware, in South Africa, it's legally required to be 2 doctors. So you might be asking, what the heck am I talking about? Because only brain dead people can be donors. It's important to realize that actually around the world, there's a whole category of donors called donors after circulatory death. And if you look at the UK, you can see that the dark blue line is brain dead donors and donors after circulatory death. So over a third of their deceased donors are actually donors after circulatory death. And then the gray line is actually living related donors. So this is now widespread practice around the world, that in the setting of palliation, you would actually include a discussion around organ donation, but the operation to recover the organs can only take place after the circulatory death has been certified. Just to give you some background, in South Africa, our donor rate per million population is 1.6 per million population. Spain gets 47 donors per million population. UK 22.5. Brazil, a South African level economy, manages to get 16.3 donors per million population. And America gets 31.7 donors per million population. And I think it's a really important thing to highlight that consent is linked to how we communicate and compassionately handle end-of-life care with the family, because a family will always have just lost a loved one, and communication is a skill that can be learned and taught. And it's something we all run away from at end of life, but I think it's really important to understand the fundamental principles behind it, because then we can communicate more effectively with families and you don't get heart transplants unless you have a deceased donor. A lot of what I've covered today, I've actually put into an online course that you're welcome to attend. It runs monthly on Coursera. There's a little paywall that Coursera does, but you can audit the entire course and get a completion certificate and just apply for financial aid. They don't audit those reasons, so you can just apply and do it that way. It's a 4-week course, but everything's put into little 5-minute videos. And it covers circulatory death, it covers breaking bad news, covers the brain death diagnosis, and with some reenactments. So if you're interested in learning more about the whole interaction between determination of death and organ donation, and what happens afterwards and what happens to the body, you're more than welcome to sign up for this course. It runs monthly on a public forum that they cohort the people who express an interest, because they're more likely to complete the course if they get given a start date. And that's what I've got for you guys. Thank you very much for listening. And thanks again for the invitation. And I've left some time for questions. So you're more than welcome to type them into the question, or the floor is yours.
Hi, Dave. That was a great talk. A lot of insight. Just have a question.
Mm-hmm.
In the Bahamas, we really don't have legislation that recognizes brain death, more cardiac death. So how is it in South Africa trying to put together legislation for brain death?
So we're covered because the legislation recognizes brain death as death, and that's in our National Health Act. We don't have regulations, because if you look at it, there's legislation, there's regulations, and then there's professional guidance. So it's the same. I think you would be held legally to the standard of what would be reasonable medical practice. So if you were to certify someone in a situation where you don't have a legal recognition of brain death, I think you would be able to use the accepted medical standard. But then there would obviously be a degree of engagement with that. I think that does open you up, if you were to use such a patient as an organ donor, to legal challenges. But I think that you would be able to certify someone brain dead using these standards, because they are so ubiquitous around the world. And there's this recent document that has really set a minimum standard that everyone would agree is applicable for a brain death diagnosis. It's interesting, the first heart transplant, if you've got someone who's brain dead and you withdraw the ventilator, they will pass away because they will not breathe. So in situations, I have had a case where a patient was brain dead, but the family didn't believe in brain death, and they asked for the ventilator to be withdrawn, and it was going to be circulatory death, and the family consented to organ donation, and that still played out that way. And donors after circulatory death the organs aren't as good as donors after brain death. And they suffer a little bit of damage because there's a degree of warm ischemic time damage during the dying process that does compromise transplant outcomes. But we're getting very good at the transplanting, that actually those outcomes are so much better than staying on the waiting list. That it's more than appropriate, and then they are approximating brain death donor outcomes as well now.
Okay, thanks.
Cool. I see some other questions. Does Vontario want to ask?
Good morning. Great presentation, Dr. Thompson. I just wanted to ask, as a critical care specialist and a transplant surgeon, do you give up your critical care duties when you're on the transplant roster?
Yeah, completely. So if I'm wearing the ICU hat, I'm wearing the ICU hat. I won't be consenting the family or doing the brain death certification. It is legislated for us as well that the doctors doing the certification can't be involved with the transplant team. So we can't get the nephrologists or anyone who down the line may potentially be looking after them to do the certification. So I actually do very little certification in case I get drafted in to operate or something, or look after these patients further down the line. My job description is 80% ICU, 20% transplant.
Thank you.
No worries. Margaret, I can see you're on.
Hi, David. Thank you
How
for
you doing?
thank you for an excellent talk. One question, two questions. Do you have an opt-in or opt-out policy in South Africa? And the other one is, do you have somebody employed at the hospital that actively goes to the ICU? Because I see where you said a lot of the time the doctors didn't, well, in the UK, they lost donors because they weren't actively noted to be possible donors. So I did a course with DTI and they were suggesting that having somebody actually go to ICUs on a regular basis to see their potential, they call them TPMs. They have some internal transplant recruitment managers where you go actively to seek out possible donors and that help increase donation.
Yeah. So South Africa's got an opt-in policy. We have an organ donor registry, which is not very functional because we're not able to access it. And it's merely an expression of intent. So you can have legislation that makes, I signed up onto the register, and then I actually don't need to get informed consent from the family. In America, it's called authorization from the family, which has a different burden of what you have to communicate. And yeah, so that's where we are. Some countries have tried to pass presumed consent legislation and to make the process easier. Brazil tried to do it and then found that their donor rates went down, and Chile as well. So I don't think that it's a one-stop fix to support, increase your donor rates. I think it's in the context of some high-performing countries and with a lot of infrastructure have passed it. And seen a moderate increase, but it comes with a degree of advertising and other things that may actually be the reason for the effect. So I'm not a big proponent of running around and saying we must change our consent system to improve our system. I really feel it's how we approach the end-of-life care as the treating doctors and the communication with the family. The suggestion to do rounds as a transplant professional in a setting outside of your own working environment is a sensitive one. People feel that they're spying on you, they're double checking how you're doing things. And I actually think it's not the most constructive way to engage it. The Spanish system performs very well because they have it mandated into their quality assurance programs for their hospitals and their ICUs, and they actually appoint someone within that ICU structure to function in that role. So it's not actually someone from outside coming in, it's actually mandated the hospital has to have someone in that role who's paid in that role to ensure good end-of-life care. So I think it's often quite misconstrued. So I don't think that the solution is that we have someone we parachute in to look through the emergency units or neurosurgical ICUs. I think you have to constructively engage with how people are approaching their end-of-life care, how they're breaking that bad news, how are they actually going about palliating patients, because if they're putting them on a T-piece and sending them to the ward, and they're not putting them on a morphine infusion and they're not extubating them, then donation after circulatory death isn't an option. So I think constructively engaging on how people do that is a more effective way. It's a slow way, but I think you can make more enemies. And even in this hospital, Chris Barnard was assumed to be the angel of death because he'd come with his ego and walked through the ICUs. He wasn't on the best of terms with the neurosurgical department. So
with your opt-in, sorry, I don't want to take up because other people have questions. With the opt-in, do you have you recognize living wills? Like, for instance, if you had knew that the patient wanted to donate, is that recognized above then the families? Because we're drafting legislation here in Barbados too, and we don't have living will laws. So, but is that recognized above what the family wants?
Yeah, so a living will is recognized above what a family wants. One of the situations legally for us is that if the body is unclaimed and there's no family, and you have a brain dead patient sitting in your emergency unit, that body actually belongs to the state. And in theory, you could get, and legally, we would be allowed to, and it's actually legislated, that we could recover organs from that body. There would be a process where we could go to that situation. We don't do it ever because actually if the family came to light afterwards and ran to the newspapers, we might have got, 2 kidneys and a heart, but we would be so damaged in the press for going against the family's wishes that actually we don't ethically proceed in that situation.
Okay.
So I think that comes down to it with the living wills as well. You do have to make an assessment of the situation. But a living will is legally a higher power than a surrogate decision maker. And I think knowing those things lets you approach the consent in a much more not forceful, but in a much more confident manner. And there's not an unknown element. You can say, and how you phrase the question, you are asking a surrogate decision maker of the family, what would the patient have wanted in this situation? It's not what they want. It's actually they're the surrogate decision maker. And that makes it easier for a family to say yes.
Okay.
The living wills take a long time to come through. So I've never been faced with a situation where you can vet a living will in the time period where actually a constructive dialogue with the family is what you still have to go through and get that box ticked. So a living will legislation is good to have as a backup, but it's not actually, we're not really well versed in it in terms of people coming to the hospital with their living will in hand. They're knocked down by a car in an accident and it all proceeds quite chaotically from there.
Totally agree. Okay, thank you so much.
No worries. Robin?
Yes, good morning. I just want to make a comment, Robin Roberts from the Bahamas. I did a transplant fellowship in 1986 in Halifax, in Canada. We had a very busy transplant unit at the time. We did about 100 transplants per year. So coming back home, I wanted to start a transplant unit. And one of the challenges we had was how do we get our cadaveric donors? And I can't emphasize the idiosyncrasies of a small community where everyone knows everyone, and you have a small intensive care unit. And so you can immediately identify those potential organ donors. And we actually started a donor program with the University of Miami, had a big transplant unit right next door. It's only about half an hour to 45 minutes by plane. And just to show you why we still have legislation to be drafted with regards to organ donation, I'll show you how we started, and we did quite a number of multi-organ donors. When the first when we had our first potential donor, we actually had the wife who actually approached us and said, listen, my husband was they just declared that he was brain dead. He had an aneurysm. And she wanted him, he was a healthy, otherwise healthy young man who was in his 30s. And she felt that she wanted to donate his organs. And so we called them. And within 2 hours, we had permission from the Ministry of Health, from the Permanent Secretary, the Minister of Health. We had to go through customs and immigration for them to come in, we had to contact the medical council for them to have temporary license to come in to harvest. But we were able to coordinate that. And then we subsequently had a hearing with the coroner because such an approach required us to have some sort of policies. We had to take the stance and justify our clinical brain dead policies. And we got a national policy guideline from the coroner's office as to how we could proceed with our multi-organ donation for in-country and out-of-country. And that has been potentially in place now for over 20 years. And so the point I want to make is that while it is important that we have formal legislation, a country can look at the practical circumstances and be very innovative to see how they can function in the interim, because nothing pains you more than to see a good potential donor just pass away. And it was very helpful for us because we were able to donate the heart, the lungs, bones, cornea, and more importantly, when we had our nationals who needed donation, we actually, since we had contributed to their donor bank, we actually therefore had some right whereby we got individuals who got a heart transplant and liver transplant. So I think it's very important to establish relationships and to look at the practical approach and to put it in the place of how your country looks at that, as you say, the end of life care. Just wanted to make those comments.
I would agree, and I would echo that completely. I think it's an iterative process that evolves over time, and I think we as medical professionals are operating with the best intentions and to the best standards that we can. And sometimes it doesn't always follow in a completely mandated sequence and there's sort of an organic evolution of it. And I think that happens everywhere around the world and is dependent on the local circumstances, like you say. But it's something that if you ask people, the majority of people will support donation. And by the time you get to, asking a grieving family, it becomes a little bit less in that context. But I think in terms of a public awareness and getting legislation passed, as a principle, no religion, no cultures against helping our fellow man. That's what we're in it for. And yeah, I think it's very definitely achievable. And it's nice to put a little framework in that gives you confidence. But yeah.
At one time, our local kidney foundation, they had a campaign, and we were very pleased at the number of individuals who volunteered to have a donor card attached to their driver's license. So you do have. I think that the public in general are aware, and I think that they favor. It's very clear, though, they want to make sure that you don't have, and I just want to reemphasize that very dangerous to have someone who is looking around in the intensive care unit or the emergency room to see if there's a potential donor. That can be very damaging.
Mm-hmm. Yeah, no, I agree. And that's why the question asking, how do I juggle the two things? I mean, I'm in a relatively big 900-bed hospital, but it's still a small community. And it's just nice to know which clinicians are informed about which aspect of where advice can be given, and not be prescriptive on it, because ultimately you may cross paths. Maybe the transplant recipient ends up in ICU on my call. I don't think I'm ethically compromised because of that link. And I think in a small community, it's important in the small islands to everyone's going to be aware of everything else. There's no way to silo it completely, and it is a collective effort. And I think one of the things is important is it's not the transplant teams, it's a collective of the treating team, not to think of every death as a failure. Offering good end-of-life care is part of that package, and helping transition that whenever appropriate into the option of donation is kind of where all countries are trying to evolve in terms of maximizing the potential.
It was very interesting. We published a paper. This would have been in the late 80s. We went through our intensive care unit at the time. We only had an 8-bed intensive care unit. It was the only intensive care unit in the country. And we looked at for a year to 2 years, what were the potential donor organs. And at that time, we were able to show that if we were vigilant, we actually had potentially enough kidneys that we could have harvested from potential donors to meet our needs at that time. We thought it was very interesting. But where in our countries where unfortunately we have a fair amount of violence, we actually were able to identify quite a number of individuals who came in with gunshots or head injuries from various causes, who would have been in the unit and we declared brain dead. So the potential is there, even in our small countries. And I think the problem that we have to do, Jamaica started transplants many years ago. And so I think that what we need to do is we need to have a system in place. We need to identify one of the countries or two of the countries which will be our transplant centers, where they will become centers of excellence, and they would be able to coordinate to harvest organs from all the other islands as needed. We had in Halifax, we catered for the 4 maritime provinces, and that's what we did. So you had a team that would go to each of the province when a potential donor was identified, and we would fly over and we would harvest the organs and bring them back. And so, you know, that's where we are in the Caribbean. It's unfortunate that we have not done that yet, because dialysis is extremely expensive, a major drain on our financial resources, and in a lot of places they can't even afford to have dialysis. So I think that it's very important that we actually look at integrating and coordinating our services and maximizing the little that we have. Until we do that, we'll never get started.
Yes, good morning. Thank you, Dr. Roberts. And so we are nearing our end time. We are past the 9 o'clock hour. And Dr. Thompson, thank you so much for joining us. I know it's afternoon in South Africa, so thank you for taking time out of your busy day in the middle of the afternoon to talk with us and discussing a very important and complicated topic for us physicians that we often find ourselves in. My only question for you was there an online course that you would suggest that we could use to help some of us who feel we need some additional training on this topic? And you already told me where to find that. So I will find that and we will share it with our doctors. Our course for this morning, or our presentation for this morning, is available on YouTube, and we've shared the YouTube link in the chat. And for those of you wishing to claim a CME, please do your feedback, and you see that the link has been placed in the chat. So thank you very much for joining us this morning, Dr. Thompson. Thank you to you, our audience, and our participant questions. Take care and have a good day. We'll see everyone on Wednesday, the 11th of May at 8 a.m. Have a great day, everyone. You're very welcome. Have a great day.